Hello, this is Dr. Helen Webberley. Welcome to our GenderGP podcast, where we will be discussing some of the issues affecting the trans and non-binary community in the world today, together with my co-host, Marianne Oakes, a trans woman herself, and our head of therapies. In today's podcast, we're going to be talking about trans healthcare in the UK today, what happens now, what we'd like to see in the future, what's blue sky thinking, and what's really achievable. So, Marianne, you've just been through the NHS healthcare route and you speak to a lot of clients who have been in that process. Do you want to kick things off, with how does it work today? What's the current process?
Well, I think the first process for everybody, I'm going to say most people, is to go to the GP. And my understanding is it should just be a straightforward process where they refer you to the gender clinic, obviously the nearest gender clinic to you. Once you get that referral, and then you are basically just sat on a potentially 2-year waiting list. Just bear in mind that 2-year waiting list is just for your first appointment. I have heard recently some gender clinics are doing interim appointments where they're not clinical appointments, they're just where they bring you in and introduce you to the service. I think that's been introduced, if I'm honest, just to make people feel less anxious. Once you do enter the service, then basically they will assess you, they will give you a formal diagnosis, and then they will plan a pathway for you. The only issue I really have with that is, aside of the waiting times, is that everything is taken away from you. You have no control over it. So basically, these people go into a room and talk about you and decide what's best for you, and then tell you what is best for you without your input. And I think that is really the early parts of most people's transition, or the early steps. It's a long process and it is a disempowering process.
Yeah.
I'm thinking then, what we experience is people go looking for alternatives because of that process. People look for alternatives, bridging prescriptions. And I think, for me, trans healthcare, certainly at the first stages of transition, is about cross-sex hormones and access to cross-sex hormones. It is a crucial part for many people of their social transition.
Yeah.
Without the cross-sex hormones, they don't feel able to start their social transition. And that is obviously multifaceted and probably for another podcast. But I think hopefully I've put in a nutshell roughly what is going on in the UK today.
Okay, so from the medical point of view, I'm just going to go back to the grassroots, really. So if you are a transgender person, you will be assigned what we call assigned a particular gender at birth. So when the midwife has a look at you when you first come out, they'll say, hooray, you've got a boy, or hooray, you've got a girl. So that is the sex you were assigned at birth. But as we know very well, not everybody grows up to identify with that sex that they were assigned at birth. So a transgender person is someone who feels very different from what society thought they were going to be. But the problem that we have from the medical point of view is that you can identify with whatever gender feels more natural for you. You can present in whatever way you want to. And by identify, I think I mean that's how you feel inside. That's how you feel inside and how you want to portray yourself to the world outside. When you present, it means what really you look like to the world outside. So when you leave your home and your final look in the mirror, that's how you're presenting to the world. So you can identify as whatever gender feels more comfortable to you at whatever time, and you can present in whatever way feels most natural and comfortable for you. But from a medical point of view, the hormone production, which defines what your body looks like in many other ways, isn't under your control. And so if you were assigned male at birth, it means that your gonads, which are testicles, will be producing male hormones, which is testosterone. And that produces the very features that we associate with maleness, which is the beard and the harsh skin and the slightly oiliness, that male smell, the angular jaw, the big hands, big feet, strong musculature, strong skeletal body. So that's what testosterone does to you. If you are assigned a female at birth and you have ovaries, you will be producing estrogen hormone instead. And estrogen gives the body the things that we usually assign with a female person. So that very soft skin, the more gentle approach, perhaps, the more emotional side of things, the breast formation, the fat on your body, which gives you hips and curves, a much more feminine, what the world sees as feminine view. And however you identify with your gender and however you present to the outside world, medically, you're stuck with the hormone production that just carries on day after day. And for many, many trans people, that difference causes a lot of what they describe as the dysphoria, which is the incongruence, the feeling that something isn't right. However you feel when you identify or however you present yourself, your hormones aren't quite right. They're the wrong way round. And I have to say, again, from a doctor's point of view, there's nothing more satisfying than when you switch someone's hormones to give them the right hormones instead of what their body is producing and which is wrong for them. All of a sudden, it's like the light switch comes on and the emotions suddenly start to match with their identity and their presentation. The skin and their bone structure and their fat around their body all of a sudden starts to fit much better with the way that they identify and the way that people wish to present themselves. And although being transgender isn't and shouldn't be a medical condition, it's not a disease, it's not an illness, it's not a disorder, it's not a problem. The problem arises in that we need doctors to help people to switch their hormones. And, obviously we want people to do that as safely as possible. So that's where the medical side comes in. That's why we need doctors and nurses to help people switch their hormones in the safest possible way. Now, you talked at the beginning, and we talked about, the idea of who makes the diagnosis or who, makes the plan for you. And in my experience, people have made their diagnosis on their own quite comfortably at home. And in fact, they made their diagnosis when they were very young. And people will tell us time and time again that from a very early age, they didn't feel right. Something wasn't right. And maybe they didn't know what to be able to put their finger on it, but something wasn't quite right. And then at some time or other, the realization comes that actually what's not feeling quite right is that everyone is expecting me to be a boy or a man, and actually I'm not. I'm a girl or a woman. And of course, completely the opposite way around. Everyone's looking at me saying you should be a happy little girl, but in fact, inside you're feeling that you're not. You're a big, bustling, brusque boy. And then not wanting to complicate things too much, but of course there are people as well in the middle who don't feel that they fit completely with male or female, or maybe they feel that they feel a bit of both, or they don't feel either. And that's where we come into the what's called non-binary or agender, which I'm going to leave alone for this podcast while we just talk about the kind of basics of the very basic medical care. So that's why we need doctors and nurses to help trans people, not to affirm their trans status, not to tell them whether they are or aren't transgender, not to try and say that you shouldn't feel that you identify with that gender or that it's wrong or right to in any way at all. What our job is to do is to make people who are transgender feel comfortable and able to identify with that gender, to be able to present in the way that they want to, and also to give them the medical support to switch their hormones if they want to. And not everybody does. So switching the hormones is that difficult or not? And there seems to be quite a big mystery about how one might do that. And basically, it's actually very easy. So basically what we need to do is to give the body some kind of medicine to stop the testicles from producing testosterone. And that can be done very easily by giving an injection which which gives the brain the signal to stop the signal that goes from the brain down to the testicles to produce testosterone. So give the injection, it gives the signal to the brain to stop the pathway that goes down to the testicles to produce testosterone. It's very easy. It's an injection that we use very commonly because we use it when we treat prostate cancer. Because cancer of the prostate feeds on testosterone. If you're unlucky enough to have cancer of the prostate, what we need to do is switch off testosterone so that the cancer has nothing to feed off. So we're well used to using these injections which stop testosterone production. And actually, we're also very well used to using them in children. There is a condition called precocious puberty, which is rare but real. And it is a condition where children will go through a very, very early puberty. For example, age 5 or 6, too early to be comfortable or right for that child. So again, we use the same injections just to stop the puberty happening, to stop the signals from the brain to the testicles to produce testosterone. So that's the one thing that you need to do, stop the natural hormone production, and then you need to give the opposite hormone. And for people who were assigned male at birth, who identify as female, the hormone that we need to give them is estrogen. And it's very easy because we've been doing it for years and years and years in women who've gone through the menopause. So women who've gone past kind of the age of 45 or 50, when their ovaries stop working and stop producing estrogen, they get hot flushes and uncomfortable symptoms and feelings and what have you, where they want their hormones back. And the way that we give them their hormones back is either by using a patch which you stick on your bottom and change it twice a week, or by a pill which you take every day. So again, these are medicines that we have been using for many, many years, very, very successfully and very, very safely. So it's not complicated. For someone who's assigned male at birth, you give them an injection every 3 months to stop testosterone production, and you give them an estrogen patch, which you put on their bottom and change it twice a week to give them their estrogen instead. And that's about it. I'd love to say it's more complicated for the other way around, but if you've got somebody who is assigned female at birth, you can use exactly the same injection to stop their estrogen production. And then you need to give them the opposite hormone. We all need hormones, so we need to give them something. We give them testosterone, and the testosterone can be given either as an injection or a gel. And again, we've been using that testosterone as medicine for a long time in men who don't produce enough testosterone from their own testicles and find a problem with that. We've been using testosterone replacement therapy for many years, very successfully and very safely. So what we're talking about is a world and a situation where people need some medical assistance, not to affirm or confirm or tell them their diagnosis, but to help them with the medication that they're going to need to swap their hormones from one to the other very safely and very successfly. Does that simplify how it all works?
I think the question that I have is, when I went to see my doctor, and I can talk about my experience, but I can also talk about the experience of some of the people I see in the therapy room. You go to see your doctor and it's almost like they are caught in the headlights. The thought of giving cross-sex hormones to a trans person feels like such a big decision to them. And I suppose what that then does is make me think, God, how safe is this? Is this going to, make me grow a second head? I don't know. There seems to be a big fear amongst the doctors. I don't know if that's a fair analysis, but that's how it came across to me. When you see a GP, that there's a fear. Listening to you talk about it, Helen, and seeing how a doctor responds, it feels there's a disconnect.
Yeah. It's interesting because historically and currently in the NHS, gender care services are at a very highly specialised level of provision. And I'm just going to explain that briefly because it's important. So there are 3 levels or 3 or 4 levels of care in the NHS. So we start off with primary care. Primary care means your GP. So that's what everyone has access to. You can just ring up, make an appointment, go and see your GP. Everybody in the UK has access to that. That's primary care. Secondary care is for something a bit more complicated that the GP can't manage, something that needs a specialist opinion or a specialist procedure like an operation or something like that. And that's called secondary care. So secondary care is your local hospital where your GP will refer you to for an opinion or for a procedure. Then we have tertiary care, which are specialist centres. So not every secondary care hospital, not every local hospital will do, for example, liver transplants, because there just aren't enough liver transplants going around to make the skills available in every single hospital in the country. So what we do is we have specialist hospitals which will do very specialist procedures like liver transplants. And so we have a core of doctors and surgeons working there who get all the referrals so that they keep their skills up to a maximum. They've got a lot of patients going through the system so that the utmost research and safety is paramount and concentrated in those special tertiary centres. And unfortunately, that's where gender care sits. Gender care sits in those very specialised services because it used to be rare. We didn't used to get very many cases of it, and so we needed super specialists to deal with it because it was unknown, it was scary, and it was rare. But what we've seen over time is that it is not rare at all. It is not super specialised, it's not scary, it's common. And, the newspapers are full of how the referrals are going up and up and up into these small specialised units that just cannot cope with it. And on one hand, you've got the NHS Constitution, which promises people that if you are referred, you will be seen within 18 weeks. And that doesn't mean actually just be seen and have an interim appointment or a quick chat or a group discussion with other patients or anything. That is a referral to treatment time. You will see somebody and have the start of your treatment plan put in place within 18 weeks. And that's what the NHS Constitution is promising us. And actually, if you look deeper into the NHS Constitution, it promises that if that's not made available to you, then it should make something else available to you. And that's where we're seeing people who, for example, are waiting on a list for a hip operation. And then they wait for a long time. And then when they reach a certain point, they'll be offered a hip operation at their local private hospital on a Saturday morning because, they've waited the prescribed amount of time and you're not allowed to wait any longer because that's what the NHS promises you. And so the NHS make alternative arrangements for you. And that would be by using private services to bridge the gap. So what we're seeing with gender services is that they currently live in a very super specialist place, which is not the best place for them. There are far too many people for the spaces and appointments available, and the waiting times are very long. And the NHS hasn't been able to provide alternatives because they haven't looked at options and they don't seem to be very many available. So then really what we need to do is take gender care out of this very highly specialised area and bring it back down into secondary care and primary care. And what we really need is a situation where we start again. And trans people who don't have any problems with their identity, they're completely happy with the gender that they identify with. They've, got no problems with what's going on at home, in their family, in their relationships, in their workplace. But what they need is the medical help. And that medical help should be available from your GP. In cases where it's a little bit more tricky, or the GP is like, well, hang on a minute, this person's had a blood clot in the past, or this person's had a heart attack, can we still switch their hormones safely? If there's a more difficult question, then that question should be dealt with in secondary care. So you should be referred to your local secondary care hospital, and they will, put in a treatment plan that makes sure it's safe for you. And then if there are super, super difficult cases, perhaps somebody who just doesn't understand their gender at all, is completely confused, has lots of different issues going through their life, through their body, through their mind. Anyone like that, maybe that's who should be going to the very super specialist services, where they might have a big team of gender specialist psychotherapists, gender specialist counsellors, gender specialist support team, nurses, doctors, voice therapists. That's what really the super specialist centres should be made of. And that, I really hope, is the vision for the future, when everyday transgender care is easily carried out by a GP and the more tricky cases are carried out by the local hospital.
You just made me think of something just listening to that there as well. You think there would be a case for separating out hormone treatment from surgeries? In other words, the specialist centres could still look after the surgeries, and actually would get referred there after they've gone through the hormone treatment.
Yeah.
Does that make sense? That because somehow, I don't want to say I support the gender clinics where surgery is concerned and having to, the hoops everybody has to jump through. But I do think, if I was a surgeon and I was about to cut somebody open, I could imagine that being a different circumstance than somebody just saying, well, look, we'll help you with your hormone treatment. So could them two, conflating them two is complicating it.
Yeah, that's right. And what we hear a lot of patients talk about is this gatekeeping situation where, and by gatekeeping, what people mean is that they know that they have a right to a certain treatment. And this is something that comes up quite a lot. Should the NHS be paying for gender affirming treatments? Why should the NHS pay for women and men to switch their hormones because they feel that they identify differently to the way that they were assigned at birth? Why should the NHS pay for that? Why should taxpayers' money go into the NHS to pay for that? If it's not a medical condition, if it's not an illness or a disease, why should the NHS fund it? But actually, that discussion has finished. That decision was made some time ago that the NHS does fund gender care. And it doesn't fund everything that a transgender patient might want, but it does fund a list of things. One of those is psychological support. One of those is gender affirming hormones, so switching your hormones to the ones that feel right for you. And another is some elements of surgery. So genital surgery is funded on the NHS, and as is top surgery for trans men. And, we can debate on many things that the NHS fund. For example, obesity surgery is quite emotive. Surgery for people who have lung cancer through smoking can sometimes be quite emotive. Funding stop smoking therapy can be emotive, but the NHS higher powers have debated on that and decided on that. And gender care has been through that process and it is funded. End of discussion. So now people shouldn't feel that they have to jump through hoops unnecessarily in order to access that treatment. And that's where we talk about the gatekeeper. When you go to your GP to ask them for a referral for gender care, the answer should be, how can I help you best to get that referral? Not, I don't think you need that referral, or that's not right for you, or the NHS shouldn't be doing that, which incidentally are things that we hear every day from our patients. But what the GP should be doing is, yes, I can refer you for gender care, and let's see how we can make this journey best for you. And I think, going back to your point about surgery, Marianne, is that what we need to be careful of is that we're not having this gatekeeper approach at any level. And for some people who are assigned female at birth, but who identify as more masculine, they've got female hormones and therefore they've got breast tissue. But the thing that bothers them most, and this is only some trans men, but a fair proportion, what bothers them most is that they've got big breasts and it doesn't feel right. With the way that they identify and the way that they wish to present to the world is that they shouldn't have breasts, because breasts are for women and this person doesn't feel like a woman. But some trans men don't want to switch the hormones. They don't necessarily want to have the things that testosterone will do to you, such as the beard and the angular jaw and the musculature and the voice breaking. They don't want that. The way that they feel that they identify and the way they want to present is with the current then kind of natural hormone pattern, but without those things on the top of their body which give them the greatest dysphoria. And the problem that we have at the moment is that in order to get surgery, you have to have gone through several hoops. You have to have lived as the gender with which you identify. And there's only two. There's only men or women. There isn't that in-between one. You have to have been on treatment hormones for a certain amount of time. And if you're somebody who doesn't want to switch those hormones, but surgery for you would be the right thing to help you identify and present and live comfortably with your gender, then it's almost like you have to have hormones in order to get the medical help or the medical procedure that you need. And that's wrong. So we need to be very careful about any level of gatekeeping at any level of whether it's primary, secondary, or the highly specialised care, really.
Definitely. I think the whole, how can I say, the social movement, is it social movement? Just society, lack of understanding where trans people are concerned, Do you think that influences the doctors? Do you think, when I spoke about the fear? And another point I wanted to come back to as well, should trans people get care on the NHS? Should the public be funding this care? And I just wanted to clarify for my own benefit and hopefully the listeners, the NHS was actually set up to help people to stay in work and to be valued members of society, that they could contribute to society. And my understanding is the research kind of shows that when trans people do get the care that they need, that they do go on to be valued members of society, that they do contribute, that their earning potential rises. And that actually that's the point of the NHS, and that would be every reason to give support.
That's something I've never thought of before, and I think it's an absolutely brilliant way of putting it. What we tragically see so often is young people who won't leave their bedroom. They won't go to school. They won't socialise out with their friends in the street or the park. They barely go downstairs because what looks back at them every day and what they see in the mirror, what they see of themselves, just doesn't fit with what and who they are. Tragic stories of children locked away in their bedrooms for the whole of their adolescence. And we see the same with adults, people who are too scared to go out into the world because everything is just feels so wrong and the wrong way round. And if we give them the support and help that they need, whether that's support and help to socially transition, i.e. present in a way that makes them feel comfortable to the world, or to medically transition so that they can have the hormone picture that feels right for them, or even surgically transition so that their body parts can make them feel comfortable and right, then what we see is these people coming out of their bedrooms, coming out of their houses, joining school, going to the park, going down to the youth club and the ice rink, trying to get jobs, actually being successful in employment and contributing to society. And that is the vision for the future of integrating trans people so beautifully into our society. And that's what we should all be aiming for.
That's linked perfectly, actually, onto, whatever we're doing now with trans healthcare. I think it would be easy to suggest that the age when people are presenting in the doctor's surgery is coming down. Historically, I'm sure it was potentially 40 plus, but the ages are coming down. So it's important, actually, that we start thinking about the healthcare on younger people. Two things, really. Are the doctors ready for that? Have they got an understanding of the social aspect of this, but also the medical aspect? At this moment in time, it takes a really brave person to work with a young trans boy or girl, because the sense I get is the first thing that people that are faced with a young person is, we've got to make sure that they are trans, that was there a cause, is it over nurturing from the mother? And they go through all these things, traumatize the child, reinforce the internalized shame that they're probably already feeling, and to see adults around you kind of go into meltdown and not be brave enough doesn't help the child. But actually, if we don't get the help to the child early enough, then, a lot of parents say to me, what if they change their mind when they're 30? And what I reflect back to them is, well, at least they'll be qualified. At least they'll have a career, that they'll be in a better position to change their mind at 30 than actually, if they don't get past 15, because they committed suicide, or they couldn't get into school and they didn't get exams, so they weren't able to find work, that they weren't able to go out and learn the social skills that you need to be able to go out into the world, to get through a job interview, that doing nothing is equally as damaging as doing, what's needed. So the long-term effects of not working with children resonate throughout their lives if we're not careful. Just one other point I wanted to say as well, going back to the NHS, one of the things I've found that isn't joined up, we can talk about hormone therapy, and this is particularly with young children, I have to say, because if they don't get the help they need, when we're just talking potentially puberty blockers or hormones, then what I see is that the mental health issues set in. And by the time a child, or anybody, but a child in particular comes to me and they've started self-harming or they've got an eating disorder, by the time it's progressed to that, then dealing with the gender identity has become far more complex. Because yes, we can help them, and we can help them to socially transition, and we can help them to feel better with their gender. But actually breaking the mental health cycle becomes, for some people, I would say, impossible. I don't want to talk about a subject I'm not qualified, but my understanding is an eating disorder, you're never free of it, once you've got an eating disorder. So not dealing with the root cause early enough, or denying it, or, not being competent enough to deal with it, actually is then going to cause more problems further down the line. I mean, in young children in particular, and I say this in young children because we do see the mental health deteriorate very quickly. When we talk of a nosedive, we're talking, it is a nosedive. They come out, the parents or whatever, it's a phase, we ignore it for 2 years, and the only time they listen is when they find that they've been self-harming. And then suddenly, what is it? This desperation to fix the self-harming then gets them to listen to the gender identity.
The mental health issues are crazy. We see a lot of children and young people and adults with eating disorders, like you say, with anxiety, stress, depression, suicidal and self-harm ideation. And, often what happens is those people go to their GP with those kind of symptoms, and the GP is desperately trying to sort out why is this depression there? Why is this person so anxious? What is this stress all about? Why is this person not eating? What can I do? And then we try all the antidepressants and mental health drugs, anxiolytics, tranquilizers, to try and abate that mental health issue. But actually, if we address the gender issue, then the mental health issues fall away. And when you've got a young person who is developing through puberty with anguish, and it's causing them such deep distress, instead of giving them all the mental health drugs, if we stopped the puberty, the mental health settles down and they can breathe and live again without this fear of puberty. Once puberty's happened and it's done its damage, as it were, then people are just desperate to get the help that they need to live and affirm their gender, and to be able to identify and present, as we said, in the way that's comfortable for them. And not being able to do that causes such anguish and distress. So, it's chicken and egg. Which came first? Was it the gender issue or the mental health issue? And our experience by far says, well, without doubt says, that if you treat the gender issues, the mental health issues get better, and people can live and breathe again, which is tremendously important. It goes back to the fear as well. You were talking earlier about the fact that the doctor doesn't want to make a mistake, and doctors never want to make a mistake. If we make a mistake, sometimes the mistake is just talked about, discussed, and we learn from it. Sometimes there's a complaint from whoever the mistake happened to. Sometimes that complaint gets escalated, and your whole career and life are put through enormous paces to see what happened in that mistake. So doctors are terrified of making mistakes, and none of us want to do that. We don't want to take an appendix out when actually the tummy ache wasn't appendicitis. We don't want to, when you're doing an operation on someone's bowels, you don't want to make a mistake and make a hole in the bowel when you shouldn't have done. We don't want to give somebody the wrong drug, which brings them out in a reaction that might cause some harm. We don't want to make mistakes. But what we can't live in a world of, a medical world of so scared of making a mistake or doing the wrong thing for one patient that the rest of the patients needing that medication or treatment or operation suffer. And that's the situation that we have at the moment. Doctors are too scared to help trans patients off their own back. They don't want to make decisions. So they either say to trans patients, no, we're not doing it, or I'm not going to make that decision for you. You have to wait in line to see someone who is brave enough to make that decision. And the problem in the UK is that we don't have enough doctors who are brave enough to make that decision. And I think what these doctors really need to do is all about education and just thinking about what this patient is asking us to do. This patient is saying, I know my own gender. I've got no problem with that. I just need some medical help to switch my hormones. Please, can you help me? And then the medication we're using is so safe, so simple. We use it in other conditions every day without even thinking about it. And when you put it like that, what we need is more doctors to come forward and say, I'm brave enough to do this. My patient is my priority. This patient needs my help today, not in 2 or 3 or 4 years' time, but today. And I'm going to be brave enough to do that. And what we then need is for our regulators and the people that govern us as doctors to back us up and say, you did the right thing for that patient there. You helped your patient, which is what doctors are supposed to do.
You used the key word for me there. You said safe. And, when we are talking about trans care, usually we talk about side effects of medication, and I know even in my own family, people come back from the doctors and they're on Googling the side effects of medication. I think when we're talking about hormones, though, a lot of the potential side effects are actually the effects that we want, that we crave. And, I've not heard of any evidence to suggest, I know that there are health risks with everything, but I've not heard anything to suggest that somebody's overall health has been compromised because they have been given HRT. Would that be fair to say?
Yeah, you're quite right. When we talk about testosterone, the side effects of testosterone are exactly what trans men or trans masculine people want. That is exactly what they want. And the risks are there aren't any. It seems blasé to say that because all medicine has risks, but the risks are minimal. The risks are what that person wants. When we talk about estrogen, it's a different matter because estrogen has been associated with risks such as blood clots, breast cancer, heart disease, and strokes. So estrogen does have those risks. But the way that I explain it to my patients is that those risks are the risks that every woman has. So by switching your hormones, for someone who's assigned male at birth, switching those hormones, turning the testosterone off, actually will protect them from prostate cancer and other testosterone-related problems. And it gives them estrogen, which will give them the same risk factors as other women have, because you're having the same hormones that half the population have. So you'll have a risk of breast cancer. You'll have a risk of blood clots in the leg. You'll have a risk of heart attacks, strokes, and what have you, that women have because they have estrogen. So yes, there are side effects to everything we do, but what we're doing is just switching you to the other risk profile than the one that you were assigned at birth, if that makes sense.
Yeah, I think if I'm understanding you correctly, what you're saying is the risks are that you're going to have the health risks of a woman if you take estrogen. And that's basically who we are. If we see ourselves as women, then we can't cherry pick the benefits, can we? We take the risks as well as the benefits, if that makes sense.
Absolutely. And also thinking about the protective bits, trans men won't get breast cancer. Trans women will have a much lower incidence of prostate cancer. So, it swings and roundabouts for both ways, really. But fundamentally, transgender medical care is extraordinarily safe, which is very encouraging, I feel. And again, it should, that feeling should give GPs empowerment to say, I can do this. There is no reason why I can't do this. And actually what we're seeing a lot of trans people, unfortunately, self-medicating, which means going onto the internet and buying stuff that they call medicines because they're so desperate to try and do it themselves. And actually GPs can say, hey, whoa, don't do that. Don't do that. I will prescribe this for you. Let's talk about this. Let's talk about I as a doctor feel the risks might be to you if you do this, what you as a trans person feel that the benefits and risks might be to you if you do this. And let's make a decision together whether we think that risk is worth it and the benefits are worth it for you. And let's make that decision together as a patient who is an expert in themselves and as a doctor who's an expert in medicines.
What would be the cost implications on a GP practice to be helping a trans person in this way?
I think cost implications, it's a very emotive subject, but it's cheap. It's cheap as chips. Testosterone for a trans man is absolutely cheap as chips, and so is estrogen. The injections are a little bit more expensive, but when actually what we have to do is balance that with what you were talking about earlier, about empowering people back into society, back into jobs, back into production for our world as a thriving and cohesive community, taking off the benefit system and into employment. So when you talk about the wider remit of funding, it's more beneficial to give trans people the care that they need so that they can get back into society. In the same way that if you compare it with, for example, anti-smoking treatment, some people think, well, why ever would we be prescribing nicotine patches or tablets to stop people smoking when it's a social problem? Why don't they just give up smoking like anyone else could? But what we see with the NHS is that it's beneficial for the NHS funds to help people stop smoking, because there'll be less heart disease, lung disease and strokes and brain disease and other cancers in the future. If we put that money in now to help people stop smoking, it saves money for the future. And that's the same vision that we need with transgender care. Put a little bit of money in the pot now, and we help someone to live and breathe and have a successful, contributory, happy life.
I think bringing it back then to, what's the state of play in this country regards transgender healthcare. And I think from what you're saying is, A, the medications that we use are really safe, that we're not, they're not dangerous drugs. The adverse effects of medication are not going to have long-term effects on the NHS. That what we're really looking at is education within the NHS, certainly within GP practices that could definitely look after the primary care. Maybe there are going to be some more serious procedures further down the line, and then they could be moved into maybe the more specialised care. Would that be fair to say?
I absolutely agree. And for me, the fundamental thing that we need to move towards is bringing trans healthcare into general practice, into everyday general practice, because your GP is the person that knows you best. They may have helped you be conceived. They may have helped you through when your mother was pregnant. They may have helped you through your childhood. They know you best, and they are the best person to understand how you fit into your current state of in your home and in society. And the best person to help you with a very, very safe medication and treatment regime. And then if you need surgery in the future, they can refer you to the local centre that does the operations the best for you, because that's what your GP will want for you. They will want the best for you. And that's what I'm hoping for. And just as a little sideline, in case this feels like just blue sky thinking, I remember 20 years ago when I was working in sexual health services in Worcester. It was at a time when chlamydia infection was just beginning to raise its head, and people were understanding that there was this kind of hidden infection called chlamydia that was causing women to be infertile. And we did an education campaign where we went into GP surgeries and said to GPs, look, when your young girls come in for a pill check, could you ask them, would they like a chlamydia swab? And everyone was like in uproar. Oh my goodness, we can't do that. We're not specialised enough to do that. What if they come back with a sexually transmitted infection positive result? What do I do about that? Goodness gracious me. And actually now, if you go for a pill check or if you go for a smear test in your local GP surgery, very, very, very commonly the nurse will say, should we do a chlamydia check while you're there? So we can make that change. We can, and I've seen changes like this happen in my time as a doctor. And I'm hoping over my next 20 years that we will see trans healthcare coming into GP level on an everyday basis, because patients know their own bodies, they know their identities, and then they just need that little bit of medical help to switch the hormones and feel happy. Thank you. We hope you've enjoyed our programme. Do go ahead and subscribe if you haven't done so already. If you or anyone else are affected by any of the topics discussed in our podcast and you'd like to contact us, please drop us a line at doctor@gendergp.co.uk. We're very happy to accept ideas for future episodes and guests, or if there's something specific you'd like us to cover. You can also visit our website, www.gendergp.co.uk. You can follow us on social media @GenderGP, and you can sign up to our monthly newsletter. Full details can be found in the show notes on our podcast page. Thanks for listening.